Kind introduction. It's nice to be amongst gastroenterologists. I get too liver focused sometimes. But my talk will be about non-alcoholic fatty liver disease. And here they call it Division of Liver Diseases, but I like to call myself a helpatologist. My dad loves that joke, so it must not be a good joke if he likes it. So just a quick outline. We'll go through some definitions of non-alcoholic fatty liver disease, fatty liver, and non-alcoholic steatohepatitis, the impact of the disease as far as its burden on liver transplant and rising incidence of hepatocellular carcinoma, who we can evaluate, who should be evaluated, folks with elevated liver chemistries, fatty liver seen on imaging, and specifically some type 2 diabetic patients who are at higher risk. What further analysis we can do with non-invasive scoring systems, vibration-controlled transient elastography, which is our FibroScan machine. And us liver doctors finally have our own MRE. It's not enterography. This is MR elastography to understand the liver stiffness. And there's still a role for liver biopsy. Yeah, I do my own liver biopsy still. And then what treatments we have. We know that weight loss is tried and true. And we have some evidence for clinical trials. And I'll go through what has been done, what we're currently doing, and I'll kind of allude to some of the future clinical trials that are coming down the pike. So first of all, non-alcoholic fatty liver disease is the umbrella. So this is steatosis seen on imaging or histology without significant alcohol usage or usage of steatogenic medications like tamoxifen, amiodarone, long-term steroid use. And then within this umbrella, the majority of patients, about 80%, fall in this non-alcoholic fatty liver. So just what used to be called just simple steatosis. And this is just defined as greater than 5% of hepatic steatosis on liver imaging or on liver biopsy. And there's no hepatocellular injury in the form of ballooning or inflammation. The more aggressive form is this NASH, the non-alcoholic steatohepatitis. This is when patients get in trouble. So they have that minimum of 5% fat, but then they have hepatocellular injury, especially in the form of ballooning. So this is just a picture to represent a pristine liver at the top, and then what looks like foie gras over here on the right. It's about 25 to 30% of the general population. This differs throughout the world. So in the United States, we're at about 25%. In the highest incidence at about 32, and then South America is about 31. And this is based on data from over 8 million patients, the majority of which were in the United States, but it was all over the world. So of those patients, some get the non-alcoholic steatohepatitis, and that's about 6% of the US population, and those are the folks who can get in trouble. Of them, some progress to cirrhosis, about 15 to 20%. And all of our patients with non-alcoholic fatty liver disease, the long-term studies have shown, the longitudinal studies have shown that there's an increased risk for cardiovascular death of 38% of these patients, liver-related mortalities, and also hepatocellular carcinoma. So what is this non-alcoholic fatty liver disease? Well, a way to kind of describe it was with the NASH CRN. So Dr. Kleiner is a pathologist from the NIH, and he developed the NAFLD activity score, which breaks down to steatosis. So it's this macrovesicular steatosis you see here, large droplet steatosis, where the nucleus gets pushed to the side. The scoring system is just based on percentages of fat seen by the pathologist. But again, all you need is greater than 5% to call it fatty liver. And the inflammation is based on how many foci they see per high power field. And the ballooning is probably the most important aspect. So here's a ballooned hepatocyte. You can see it's got kind of these scalloped edges. You get these ropey perinuclear inclusions, which are Mallory-Denk bodies. And they have deranged cytokeratin. So you can see that that's causing their structure to look kind of funny. The scoring is only 0 to 2. Kleiner just recently gave an oral presentation talking about expanding the scoring for ballooning up to 5 because we're realizing how important the ballooning aspect is to the progression of disease. Furthermore, Dr. Bedosa is a pathologist out of France, a renowned liver pathologist, and he was helping to kind of come up with algorithms for pathologists to better describe, is it fatty liver or is it NASH, the gestalt of NASH. And again, all you need is 5% fat to call it fatty liver. But you do need some ballooning and some inflammation to really call it NASH, as opposed to just this simple steatosis, just the fatty liver. And so now we'll talk a little bit about the burden and why we should care about fatty liver disease. So there's these green bars represent the total number of liver transplants done in the United States. You can see it's between 5,000 and 6,000. It's been pretty steady. And then over here we have the number of liver transplants per etiology. So Hep C is still at the top of the list. You can see the increasing burden of NASH and still alcoholic liver disease that are taken over. And we have our new medications to treat hepatitis C. So it's estimated that by 2020, fatty liver disease will overtake hepatitis C for the #1 reason for liver transplant in our country. And just a further breakdown to show you the increasing rise of non-alcoholic and alcoholic liver disease in our country and the reason for transplant. This is actually a study done by one of my co-fellows. So she went through the transplant registry and just focused on patients who are under the age of 50. And they found that NASH has actually surpassed hepatitis C for transplant in that age group. You can see a fold change from 2002 to 2014, how NASH is on the rise and Hep C is actually on the decline in this age group getting liver transplant. So it's already starting to happen, the switch. This is a great graph to show you guys from National SEER database. This is just the incidence of cancer. So you guys are doing a great job with colon cancer. It's on the decline. However, liver cancer is on the highest rise amongst both men and women in this country. And we think part of this is the increasing burden of NASH. Okay, so who's at risk? So patients with elevated liver chemistries. And this is ACG guidelines to show that the actual upper limit of normal for males should be 30, and for females it should be 19. And part of this is because the older upper limits of normal, they didn't know what hepatitis C was. And so now that we know that, we know we should actually lower the limit. And I just wanted to put, EPIC actually has one of the lowest upper limits of normal I've seen at 45. We still use ECW at Mount Sinai West, and they use an upper limit of normal of 70, which is a little scary. And you can see if a patient has an ALT of 80 and your upper limit of normal is 70, you don't get as worried. But if that's a female, that's like 4 times upper limit of normal for me, so I get quite worried about NASH. And this last statement is just to tell you that if you have imaging with steatosis and you have these abnormal liver chemistries, it actually increases your likelihood of having that more aggressive NASH. So we need to be cognizant of these liver chemistries. And then this is the work one needs to do, because I don't have a blood test for NASH. It's a rule-out disease, so I need to be thorough and most importantly take a history to see if they're drinking significant alcohol, if they're on any of these steatogenic medications, to see if they're immune to hepatitis A and B, if they're in the age cohort, especially look for hepatitis C, and rule out all these other diseases here, autoimmune, hereditary hemochromatosis, Wilson's disease, alpha-1 antitrypsin, and then consider imaging and potentially these other modalities that I'll go into in just a bit. And actually, I was reading a paper. They were saying that the average gastroenterologist orders about $3 million worth of tests a year. The average hepatologist orders about $5 million worth of tests a year. We have all these rule-out tests we have to do. The hospital loves it. So so we talked about elevated liver chemistries. Now we'll talk about incidental fatty liver disease seen on imaging. So if you see abnormal imaging, you look at their liver chemistries. And if they're abnormal, so greater than 30 or 19 for males and females, they need to be worked up as fatty liver. If they don't have abnormal liver chemistries, we still know that 25% of NASH patients will have normal liver chemistries. And so you will look at features of the metabolic syndromes. Do they have features of the metabolic syndrome, which most of them do? Then they should be worked up as non-alcoholic fatty liver disease. Well, if they don't have features of the metabolic syndrome, you need to take a careful history and see if they're drinking a lot or if they're on one of these medications that can potentially cause steatosis. So again, these are the ASLD guidelines that just came out. Most of my slides reference that. So we know that type 2 diabetics are at increased risk of NASH. And they recommend stratification by looking at the level of fibrosis in these patients and using things such as the NAFLD fibrosis score, the FIB-4 score, or the vibration-controlled transient elastography, which is our FibroScan that we have. Elastography is also a useful clinical tool to use in these patients. And fortunately, we have 4 of them here at Mount Sinai. Most institutions are lucky to have them. So this is something that we can offer to our patients. And just to review fibrosis, in fatty liver, it's a little bit different. And this is the Brunt classification for fibrosis. So F0, of course, is no fibrosis. F1 is sinusoidal fibrosis. It's this chicken wire fibrosis you see here in blue. Nobody saw in trichrome. And then F2 is sinusoidal plus periportal. F3 is classic bridging fibrosis. And F4 is our cirrhosis. This top one is just a serious red. It's not something we use as much in clinic. We use it more for research. But the beauty is it just stains collagen red. And then we can use morphometric analysis to understand the collagen proportional area to get like a metric, a number, where we can't do that with the Mason's trichrome. So this was a great longitudinal study done in about 300 patients with varying degree of fibrosis that they watched over time. And you can see the degree of fibrosis really matters. So our F3s and our F4s especially were at increased risk of dying. Their survival probability starts dropping off over time. So these are people we need to be hyper-vigilant about. The prevalence study was a nice longitudinal study done over 700 patients from all around the world, US, Asia, South America, Europe. And I've told you many of these histological features. The only thing that really panned out for survival was actually fibrosis. So it's great to come here to Mount Sinai, where Scott Friedman has discovered that cell. We do great work on fibrosis here because fibrosis matters. You can see the hazard ratio for stage 1 fibrosis already confers an increased risk for death and liver transplant. And as our stages go up, so does the hazard ratio. The other things that kind of panned out were increasing age, if you had diabetes, patients who smoke. And interestingly enough, statin was a protective mechanism in these patients. And while I'm a hepatologist, I'll often calculate the AHA risk factors on these patients. And if they meet the criteria for primary prophylaxis for statins, I'll start them on a statin. And even if their liver numbers are a little high, I'll start them on a statin. That's a routine consult I get from some of our providers that their patients have mildly elevated LFTs. We want to start a statin. We're a little afraid. So please start it on these NASH patients. We know there's a protective role. So how can we evaluate these guys further? How can we risk stratify them? So there are several non-invasive scoring systems, but the AASLD recommends using the NAFLD fibrosis score, and it recommends using the FIB-4 score. So we'll go through the NAFLD fibrosis score. You can just Google the online calculator, and let's walk through this patient together. It's a patient that you probably commonly see in your practice, a 62-year-old, let's say it's a 62-year-old male who his BMI is 33, he has diabetes, his AST is 30, ALT is 60, so we know that's elevated. Platelets are 175. The one caveat with this system is the albumin is in grams per liter, not in grams per deciliter, so please remember to convert. So in our system, this would be 3.4, but here it's 34. And if you look with the scoring system, it's 0.827, which actually predicts there's an increased risk for the presence of advanced fibrosis, F3, F4. So we need to evaluate this patient further. They're at risk for mortality from potentially NASH. And I'll admit, when I was a resident, if I saw these numbers, alarms wouldn't be going off in my head. But nowadays, all kinds of sirens are going off, and we know we should evaluate this patient further. FIB-4 score was developed at VCU. One of my mentors, Dr. Sterling, developed this for co-infection of Hep C and HIV. And then it was further developed by Shah and Dr. Sanyal at VCU to be used for non-alcoholic fatty liver disease. And the cutoffs are different. I will warn you that. Again, you can Google this. find it quickly. You probably have the app on your phone. And it uses the parameters of age, AST, platelet counts, and ALT. So usually information that's already in the chart before you see the patient. And I put a patient that's grossly cirrhotic here. So a 65-year-old, platelet count of 150, AST is greater than ALT. And you can see it gives you a score of 3.56. And with our cutoffs for NAFLD, it's greater than 2.67. The patient is likely to have advanced fibrosis. So this is somebody who's at risk. It is initially, but as they go to cirrhosis, those are the things I'm looking for. When the AST goes greater than the ALT and the platelets start to tank, that's when patients are having cirrhosis and they're starting to have evidence of portal hypertension and probably hypersplenism. But you're absolutely right. Typically, when you see the patient earlier on, it's the ALT greater than AST, and they're very mildly elevated. You don't see them in the 300s. Yeah. Oh, yes, sir. Sorry, the image didn't come out great when I converted it over here. But yeah, it's a square root of the ALT. You can just plug it into your phone usually. And actually, when I was at the VA, they just had this because these numbers are always there. They just had like another column, just put out the fib for you. That's something we're working on here too, just to have that put in there for you. So the vibration control transient elastography, the FibroScan, this has kind of revolutionized the field of hepatology and actually decreased the number of liver biopsies that are being done, especially in viral hepatitis. And we have portable machines. I take one all around the city to my clinics with me. It has a rolling suitcase. And really all it does is it puts a probe over top of the liver and it just taps the sound wave out. So you can feel the thumping on your liver. It takes 2 to 5 minutes to do, gives you results immediately, and we interpret for the patient immediately. So it's a fantastic machine. And it gives you 2 scores. It gives you a liver stiffness score to understand the amount of fibrosis in the liver. And it also gives you a controlled attenuation parameter, which estimates the amount of steatosis in the liver. There's an M probe, which looks at a vector that's 4 centimeters long, and it looks 2 centimeters underneath the skin. And then there's an XL probe. The Europeans joke around and call this the American probe because we're so much bigger. This is the same 4 centimeter vector. It just looks a little bit deep. Okay, and there's all kinds of parameters on the machine that we can look at to make sure it's a quality study. There's set metrics for that validation. But I will say that FibroScan does vary for the disease state. We have to be cognizant of that. The numbers are not just standardized. So you have to understand which disease state the patient has. And NAFLD tends to be some of the higher numbers that you will see to differentiate between F2, F3, and F4 fibrosis with the machine. And Dr. Afdal will be here next month to give medicine ground rounds, so I highly encourage that you guys have the opportunity to go and hear him speak. He's done a lot of work with FibroScans, with viral hepatitis, and also with NASH. And so to further validate, the CAP score is newer than the kilopascal score, but they did some pretty good validation. So this was a French study. The FibroScan was actually developed in France, where they had 236 patients. And when you do a FibroScan, it's in the exact same position. The patient goes in the exact same position as you would do a liver biopsy. So what they did is they did the FibroScan, they marked the spot where they did the FibroScan, and the patient had a liver biopsy the same day. These are all patients who are having liver biopsies. And they used some with the XL probe and some with the M probe. The machine will tell you if you're using the M probe and they're not getting good reads, it'll prompt you to use the XL probe. And so these are the practical cutoffs that they came up with. That S1 is greater than 240 decibels per meter, S2 is greater than 270, and S3 is greater than 300. And again, all we really care about is if there's greater than 5% fat. That's fatty liver disease. And then this is our MR elastography with proton density fat fraction. So the numbers are a little different for the kilopascals because they use Young's modulus. So you have to multiply the number by 2.5. But this top row is the PDFF, and this quantifies the amount of fat in the liver. And I was speaking with the radiologist. They said they've gotten it down from 16 seconds to 4 seconds. So it literally only takes 4 seconds in the MRI machine to get a PDFF, which is phenomenal. The MR elastography takes a little bit longer, so instead of just a probe kind of tapping over the liver, it's an entire paddle that goes on top of the patient and kind of thumps the liver. They go in and out of the MRI machine. I've only seen videos, it looks pretty neat, but it's not painful at all, and it'll give you a score. So, some of the limitations with the FibroScan or biopsies, we're looking at the selected area. So people talk about sampling bias. So this had very good area under the receiver operator curve because it looks at the entire liver, and we know that it's not homogeneous with the fibrosis and also with the disease states. There's variability within this large organ. And this was a nice study done out of UC San Diego. They're one of the leaders when it comes to MR elastography in NASH. So they just went to a type 2 diabetes primary care clinic, and they asked the first 100 patients they saw, do you want to have an MRI PDFF and an MRE? And 98 of the patients said sure, and actually showed up. When they did this, and they screened for just greater than 5% fat, so again, that's just for the diagnosis of fatty liver, 65% of the patients had fatty liver disease, okay? And these are patients who were not known to have any liver disease. So, and then they looked for advanced fibrosis, so looking at 3.6 kilopascals, which would equate to 10 kilopascals on the FibroScan. They had 7.1% had advanced fibrosis, and these patients had no idea. And I routinely will see, so last week I saw 2 patients who were known in the diabetes clinic who came to me for new diagnosis of cirrhosis. And when I talked to the patients, they said, hey, I've been told I had a fatty liver for over 15 years. How come nobody's ever done anything about it? And their numbers were slowly drifting and changing like we talked about. ALT was greater than AST, they slowly flipped, and they started to have thrombocytopenias. So we have to be very vigilant about this. Just for the sake of time, I didn't include some of the data we've done here. We've been using FibroScans in our diabetes clinic and also in our obesity clinics. We're finding about the same rates, even slightly higher, 75% with fatty liver disease. And we have a unique population as well with our diversity here. So,
those data on diabetics, is that factored into the MRI, or it's all comers?
This study was all comers. All comers.
And if you looked at people with diabetes and elevated BMIs?
Yeah, so they've realized there have been a lot of studies. So each feature of the metabolic syndrome that you add on, the more likely you are to have the NASH. Absolutely. And obesity pans out to be the most important when it comes out. Yeah.
Precisely. Would you told a patient in San Diego 15 years ago?
So 15 years ago, it'd probably be weight loss. There's not much to do.
That's what they were telling you.
Yeah. Well, I took out some of the slides about behavior, but I'll oftentimes, try to speak to the patient to understand. A lot of people have use eating as a coping mechanism, and nobody really talks about that. So they oftentimes need to see a psychiatrist or even a behavioral therapist to work on this. And we started collaborating with Mount Sinai's weight loss clinic, and they have a 15-year track record. So they're an interesting clinic where the average BMI is 43. The patients come in there, and all they do is group therapy once a week. That's all they do, just talk to patients. And after a year, most of them have lost on average 9% of body weight, which is phenomenal. And that's why I got kind of excited. I'll show you later. And we've been FibroScanning those patients to try to understand who has liver disease and also how things are changing as they're losing weight, to really describe that further in this morbidly obese population. But I think the worst thing you can tell the patient is go lose some weight. They know they need to lose weight, and I think it only disconnects you further from the patients. The way I engage them, I ask them, what are you doing to lose weight? And most of them say nothing. And so I say, well, let's talk about it. Let's talk about portion control. Let's talk a little bit about a plan, things that we can do to initiate this. And I'll admit, when I came here, my BMI was 30. I said, I can't be that fat doctor telling patients to lose weight. And I started practicing what I preached. I practiced portion control, and I've lost 20 pounds since I moved here. And I'm not walking anymore. I looked at my Fitbit. It's all the same. It's just simply portion control.
I've lost weight since
Yeah. Yeah, this stuff's all, I could talk for hours to you guys, but I'll move forward. But there's still a role for liver biopsy. And it's to make the diagnosis of NASH and to understand the prognosis and also to initiate drug therapy. So I'll routinely do liver biopsies and for standard of care, and then use that same liver biopsy to try to get them into a clinical trial. So it's kind of like 2 for 1.
Why is it necessary if these other measures are so good?
They're pretty good, but they're not. This is the gold standard, you know. So if you look at the area under the receiver operator curve, fibroscans are at about 0.85, and then the MR elastography are like 0.92. But
Unfortunately, that study you showed us where they did a almost simultaneous.
it looks really good. No, you're right. But it's unfortunate that most of the clinical trials you need a liver biopsy. And so I have had certain situations where the patients were quite obese. I did a liver biopsy on a patient who had a BMI of 50, and when we did the fibroscan, it looked like he had F3 fibrosis and NASH, but when I actually did the biopsy, he only had F1 and NASH. And because these studies aren't as well validated at the very high BMIs, and in those settings, I need to do it as a standard of care. But we also do it to rule out other causes of liver disease. You know, nowadays it's whatever disease plus NASH. So, you know, we're seeing I biopsied somebody recently who was known to have autoimmune disease, who was Asian actually, and her BMI was 28, that's obese for Asians. We have to be cognizant of our diverse patient population. And on the biopsy, it was NASH and autoimmune hepatitis. So it was a new diagnosis of NASH for her. And that just goes with the obesity epidemic that we're seeing in our country. And we have IBD patients who are obese, which is not necessarily, you know, what it used to be 20, 30 years ago. So risk stratification in patients with suspected NAFLD. This is just an algorithm to think about. So, you know, especially patients who have steatosis on imaging and elevated serum ALT, we need to ask them, you know, are you drinking? Are you taking these medications? We have other causes for elevated liver enzymes. And if not, then we've confirmed NAFLD. But we have to risk stratify these patients. Patients who aren't obese, and again, we have to take into account the ethnicity of the patient. If they're younger, they don't have type 2 diabetes or features of the metabolic syndrome, their scores are all low. These are patients I would not biopsy. I'll just continue to follow them and reassess them and see if there are other risk factors that are evolving, you know, especially if there's a lot of weight gain in the patient over time. Then I'll consider to maybe repeat some of these studies or even move to a biopsy. The folks who are in the intermediate range, so who are obese, over the age of 40, have features of the metabolic syndrome, have indeterminate scores or F2, F3 fibrosis on the FibroScan. Those are patients I need to consider doing a liver biopsy on, just to understand what's truly going on in those patients. And then patients who I'm more worried about who have advanced fibrosis, those are patients who definitely need to be worked up because they can start to develop complications from portal hypertension and have liver-related mortalities. And then just to tell you, we're working on a referral for FibroScan. It's in beta testing so that you can just type it in. The patient will just come to one of our many centers around the city, have the FibroScan done, we'll interpret it, and if it becomes worrisome, then we'll just set them up for an appointment to officially see the hepatologist. But whenever a FibroScan is done, a hepatologist goes into the room and explains to the patient what the findings are. And we'll write it, there'll be a note in Epic and explain it to you. We're working on dot phases for NAFLD fibrosis score and FIB4 score to not only give you the number, but to interpret it for you, to let you know the next step of action for your patients, and just to make it very simple for our providers. So the treatments, we talked about weight loss, and there are some pharmacological therapy. So weight loss, the best study is actually out of Cuba, and that was a couple of years ago, where they had 200 some patients, and they asked them, you know, try to cut down your calories from 300 to 500 calories, down to by 300 to 500 calories a day. And just try to walk more. That's all they asked them to do. 30% of patients were able to lose 5% or greater body weight after a year. So they did the biopsies, they asked them to do the interventional weight loss, and they did the biopsies again after a year. And we see that with 3% weight loss, you can decrease and actually reverse the steatosis. At 5%, you can eliminate features such as ballooning or inflammation. And with 7% or greater, you can actually resolve NASH. I think the most fascinating is after a year, if you can lose 10% of body weight, you can actually have fibrosis regression. And this is something I show every one of my patients, and I talk to every one of them about, because we know that weight loss is the only tried and true intervention that we have.
What other intervention?
Well, we're going to get into the others upcoming, but as of now, I have nothing else. I have nothing FDA approved except for clinical trials. There are some, and that's what we'll go into now. So no FDA approved medications. There are some therapeutics available, but they're not FDA approved, and they have many issues, such as vitamin E, pioglitazone, and liraglutide. Then there's some more limited data with agents that are in phase 3 trials that we're currently studying their ongoing clinical trials. That's what I'll focus on for the rest of the talk. So PIVENS, this is pioglitazone and vitamin E for non-alcoholic steatohepatitis. This is the New England Journal paper in 2010. This is the first paper to show efficacy. And the endpoint that they used, and the reason I bring up the endpoints is because they've kind of changed throughout the studies, and I want to talk about that evolution. So the initial endpoints they used were improvement by 1 or more points in ballooning, because they used the NAFLD activity score we talked about earlier, no increase in fibrosis, neither decrease in NAFLD activity score to 3 or less, or a decrease in NAFLD activity score of at least 2 points, with at least one of the points being in inflammation or steatosis. And this is kind of before they understood the importance of ballooning. So there was the non-diabetic patients that they studied. They biopsied them at the beginning of the study, gave them either pioglitazone or vitamin E, and did biopsy or placebo, and then biopsied them again at the end of the 96 weeks. And this is just to show you histologically overall improvement. Well, even the placebo improved by 20%. And we're seeing this throughout all the NASH trials that even the placebo improved by 20%, which is a really high number. But vitamin E did improve more so, and so did pioglitazone. And when it came to resolution of NASH, that gestalt you see on pathology, again, even the placebo, 20%. And then vitamin E improved by 36%, and pioglitazone improved by 47%. But vitamin E does have some potential safety concerns, especially giving this to a younger man. There's a potential risk for prostate cancer, all-cause mortality, and hemorrhagic stroke. So it's not routinely used. We aren't using it that much, and also excludes from clinical trials. Pioglitazone is a TZD, and it's really fallen out of favor. I don't see too many diabetologists ordering this medication. There's risk of heart failure, and these patients all gain weight, which kind of counter to what our goal is for the patients to lose weight. But I will emphasize, it's pretty impressive that the placebo group loses weight. My obligation is to the patient. So if they can, resolve their NASH completely just by being a placebo, then that's great. I call this the dentist effect. These patients are being seen more frequently, and maybe we're sub-selecting a group of patients that will do better. I tend to brush the heck out of my teeth before I go to the dentist, so maybe they're just acting a little bit better. We don't really know, but I'll take it. 20% is pretty good. So liraglutide is available. They use it in diabetes all the time. And they did this is a phase 2 study that was published in Lancet not too long ago. And it looks like it has an effect for resolution of NASH. So of the group that received the liraglutide, 9 of them are diabetics. And of the group that did not receive liraglutide or got the placebo, 8 were diabetics. And of the resolution of NASH, neither of these 2 patients had diabetes. And of these 9, 3 did. There was an effect. And really the effect is through weight loss. These patients lose weight with GLP-1 analogs. There was a signal in ballooning, but there wasn't a signal in inflammation. There wasn't a signal to improve fibrosis, but there wasn't worsening of fibrosis. So it seems like there is some utility in this drug, but it doesn't hit all the boxes. And a single agent is probably not the answer anyways. So this is something to consider. But as I'm fiber scanning our diabetic patients, I'm keeping a track of who's on GLP-1s and SGLT medications, so we can see if there's a signal there. FXR got a lot of attention not too long ago with Intercept and their development of obeticholic acid. So FXR is a nuclear receptor for bile acids. Quinodeoxycholic acid is our endogenous bile acid that has the most activity for this. Obeticholic acid is a tweaked version of quinodeoxycholic acid, and it has 40 to 100 times the affinity to FXR. And FXR has complicated pathways by activating its small heterodimer partner, activation of steroid-regulatory and elemental binding proteins that ultimately lead to decreased plasma triglycerides and free fatty acids, increased beta oxidation through PPAR alpha mechanisms, and also increased VLDL receptor activation, causing more clearance. But also through the scavenger receptor decreases the HDL. So there was potentially some worry when they were using this. But you can see that this was another paper to show the efficacy of obeticholic acid in NASH. It was a double-blind placebo-controlled trial where they gave 25 milligrams of obeticholic acid versus placebo, biopsies at the beginning, biopsies at the end of 72 weeks. And again, so improvement in NAFLD activity score without worsening of fibrosis, 45% with obeticholic acid, and placebo, again, 21%. An improvement of fibrosis, there was a signature here with the obeticholic acid, but again, placebo, 20%. The downfalls or potential pitfalls of this medication are that there is some pruritus noted in these patients that was dose dependent, but was relieved with medication, typically just antihistamines, but we had to escalate in some situations. Decreased the HDL. Unexpectedly, it increased the LDL. And it was pretty easy to tell who was taking placebo or medication when you watched their LDL. And most of them responded to statins if they weren't already on a statin, which didn't really bother me because they showed you statins are protective. But you could tell who was on it. So now we're in the middle of the phase 3 trial where they're using different dosages of the obeticholic acid to help with those side effects we discussed. And we're actively enrolling, really looking at stage 2 and stage 3 fibrosis. And you can see this phase 3 study is planning to go 6 years and have multiple biopsies. Initially, the phase 2 trial was planned to go much longer, but the interim analysis looked good. So they shortened it. So we're hoping that it will be shorter. But it's a bit of a tough sell to patients to say, hey, we're going to put you in a 6-year study and biopsy 4 times. But that one's a bit tougher to sell. But I always, I'm a glasses half full kind of guy. I remind them that, hey, 20% of you, even in placebo group, are going to get better. And my obligation is for you to get better. That's what I want. Not for the drug company to make money. I want you better. So I'll quickly go through the inclusion. So these are stage 2 and stage 3 fibrosis. This arm actually filled up, so I won't go through this anymore. This just closed recently. They were looking at stage 1 fibrosis as well with other risk factors of the metabolic syndrome. The exclusion is excessive alcohol consumption, bariatric surgery or ileal resection because the enterohepatic circulation of bile acids and the absorption. Out of control diabetes, other forms of liver disease. They really did want patients with high MELD scores and just some lab parameters they're looking at as well. And they wanted stable doses of statins and PCSK9 inhibitors for at least 30 days. No biliary diversion for the same reasons we talked about earlier. They didn't want HIV patients. And also, because they were worried about the cardiac issues, especially with the LDL rising, they didn't want any cardiac events in patients. They didn't want these people who had prior exposure to obeticholic acid. And I'll talk a little bit about PPARs. So we talked about TZDs being a PPAR medication used in the Hibbins trial. That's PPAR gamma. And that's an insulin sensitizer. It regulates lipid metabolism and has those side effects we talked about earlier. PPAR alpha phenofibrates one of these. It's expressed in the liver, modulates fatty acid transport beta and fatty acid beta oxidation in the liver, decreases triglycerides and increases HDL. And PPAR delta induces hepatic fatty acid beta oxidation, inhibits lipogenesis, increases HDL. So it looked like these look like favorable traits that we would want. And the golden study is with elfibranor, and it's a alpha and delta agonist. And you can see that in this phase 2 study, they looked at 276 patients with placebo and 80 and 120 milligrams, followed them for 52 weeks, and again, biopsies at the beginning and end. Their primary endpoints were resolution of NASH without worsening of fibrosis. But interestingly, when they started the study, they had a protocol-defined definition that said, we're going to define this resolution of NASH as absence of at least one of steatosis, ballooning, or lobular inflammation, and no worsening of fibrosis. And then later they updated it to make it a little bit more stringent. Defining the resolution as disappearance of ballooning, and overall histological change from that gestalt of from NASH to just the fatty liver disease without progression of fibrosis. And one of the reasons they did that, you can see, so here's the protocol-defined primary outcome. So it's the 274 patients. Of them, 274 total. 234 had NASH scores of 4 or greater, and 40 had mild. In the placebo arm, that breaks down to 92, 76, and 16. And when you look at the percentage of patients who met the protocol-defined primary outcome, it was again quite high in this placebo. So 17, 11, and 50%. And then elafibranor also at 80 milligrams had these percentages, and at 120 milligrams. Then when they changed the definitions, you can see the placebo number dropped down quite a bit. And you could say that they were playing games with statistics here and definitions, and it's all kind of post hoc, so you have to take it with a grain of salt. Let's be honest there. But it looked like there was a signal, more so of a signal, when they changed the definitions and using 120 milligrams. And the conclusions were that it demonstrated histological efficacy. Resolution of NASH was achieved, especially in those with the moderate and severe NASH activity scores at 120 milligrams. And there was improvement in fibrosis, improved lipids, improved insulin resistance, and it was well tolerated. And so now we're in the phase 3 trial of this. We're actively enrolling. It's a 72-week long study for the first biopsy. Then we follow them even longer and do another biopsy, looking at those primary endpoints that we talked about, and really trying to prevent advancement to complications of advanced fibrosis and portal hypertension and liver-related mortality in these patients. And they're a little bit more liberal with the ages here, from 18 to 75. There's lots of liver biopsies. Again, stage 2 and 3 fibrosis, and they can be on stable medications, and you have to control the diabetes. They don't want patients with bariatric surgery. They want stable doses of fenofibrates because that's also a PPAR activator. And I won't bore you guys with those details. Another medication that's out there is ASK1 inhibitors. So this is apoptosis signaling kinases. This is a Gilead medication, kind of focusing on its effects on fibrosis and evading apoptotic pathways and macrophage recruitment. And this is just to show you that, this is a paper from VCTE. So toll-like receptor 4 activation, which we know the gut microbiome shifts in NASH patients towards a more gram-negative species. They're actually using that as potentially diagnosing patients with NASH to see that gram-negative shift. Will activate toll-like receptor 4, and in turn lead to apoptotic pathways. So you can see ASK1 is involved in that pathway. So, the initial phase 2 study was kind of funny when they did this. So it was a 24-week study, and they used this LOXL inhibitor in combination with the ASK1 inhibitor. They did liver biopsies, they did MRIs, but the LOXL inhibitor didn't work. So they said, well, that's going to be our control. Whenever there was a LOXL inhibitor, that would be the control. So it was a little odd the way they did this experiment, or this clinical trial. And so they considered the LOXL the placebo, and again, you can see the placebo effect is about 20%, and there was reduction of fat on the MR elastography with PDFF, and there looked like there was a signal with the ASK1 inhibitor at both doses. So now, it's just to show you the same, that at the different doses, there was increased improvement of NASH, and also those who were stable without worsening the disease compared to what they call the control, this LOXL1. But it's not a cleanly designed experiment by any means. But that hasn't stopped Gilead. They've already moved on to phase 3 trials with this medication, looking at focusing on F3 and F4. They're calling these the stellar studies. Actually, the Stellar 3 just closed a couple days ago. They filled their number. Now they're focusing on the Stellar 4 study, looking at the cirrhotic patients. I won't bore you guys with this, but again, another long study. And they're already starting to do, Gilead is going to have another clinical trial opening up in a couple months using this ASK1 inhibitor, their own version of an FXR agonist that doesn't have the side effects we talked about, and an ACC inhibitor. So to focus on de novo lipogenesis, and that has 7 different arms in it, with real placebos, thankfully. So Gilead is one of the most aggressive in this space right now, but I will applaud them that they're using multiple different agents as a way to treat these patients, and I think that's that's a good thing. I don't think we're going to have a single agent that's going to check all of our boxes. With for time, I'll kind of move a little faster. But another agent that we've been looking at is a chemokine receptor blocker, and this is just to show you that there's complex macrophage activation that will lead to stellate cell activation and ultimately lead to scar formation and fibrosis. And these can come from toll-like receptor 4 activation, damage-associated molecular patterns, etc. There's a lot of pathways. And this paper just came out recently in Hepatology, looking at a Ceniceviroc, which is a dual CCR2 and CCR5 antagonist. It was a 52-week phase 2b study where, again, liver biopsies at the beginning, liver biopsies at the end. Didn't look that great, to be honest with you. But the one kind of nice thing about it, it looks like it didn't help at all with NASH, let's be honest, but it did help with a little bit with fibrosis. The placebo group improved by 10%, and then the drug group improved by 20%. But we'll see if that's going to pan out over time. They're expanding this to phase 3 already, and we're watching it. But again, maybe this will be good for a combination. And if we can help with the fibrosis and have other medications to help with the ballooning, et cetera, maybe. But just to show you, this is kind of the landscape now. And it's a very similar inclusion and exclusion criteria. And so the elafibranor study is still ongoing. Stellar 3 literally just closed this week. Stellar 4 is open. Regenerate is open. And we have one that will open shortly for the multi-combo drugs. Regenerate is the obeticholic acid, and they're opening up another study in the next couple months to look at obeticholic acid in our cirrhotic patients to see if they can reverse that. There is a little bit of a concern with the black box warning for obeticholic acid in our PBC patients. We have to be very careful with the study to make sure they don't decompensate. And then there's the Aurora study, which is a Ceniceviroc study I mentioned to you. And we also have an FGF19 agonist study that's coming out shortly that it's kind of along the same pathways as bile acid activation. So there are a lot of clinical trials already going and coming down the pipe, so that's a good thing for NASH. Hopefully we can have some FDA-approved medications in the next few years. These studies are all going to take a lot of time. And just to show you, I'm kind of all over the place, so I have clinics at St. Luke's, Mount Sinai West, at CAM and at the FPA, and we have the FibroScan in all these locations. So if you ever need a patient who you'd like to evaluate further, we can help you with that. And then, just because I had so much fun with you guys, the Iron Chef, I was wondering if we're going to have a rematch, liver versus lumen. I just got married recently, and my buddy bought me a precision cooker, so I used it on Monday. I cooked pork belly for the first time with ribs, and this is what it looked like after I sous vide it. And then I crisped it up here, and then I get points off for presentation in the Ziploc bag or in the Ziploc container here. But I just want to let you know that we're practicing. We're ready for you next year. Thank you all. I really appreciate your time.